Good evening, everybody. We'll just give it a moment to let everybody make their way in. Good evening to those on the East Coast who might be watching like while they're laying in bed. But I'm so honored to be here. I know it's a late night for the East Coast, but giving everybody the opportunity to join this wonderful presentation. So how are you, Dr. Karpecki?
I'm doing great. Thank you very much. How are you?
I'm good. Are you East Coast or are you?
No, I'm East Coast. Kentucky's one of those split states. Half is central and half is east, but I'm on the East Coast side. But this worked out great. I coached my son's hockey team and he had a practice, so it went to like 8:30. So this was perfect.
I was saying I was watching Netflix and had to like make sure I paused it to come up here.
Or
So,
people watching the football game, Notre Dame, whatever. Yeah.
well, it looks like we have a lot of people coming in, and I want to make sure we have plenty of time because I know there's going to be a lot of questions at the end. So, welcome to tonight's Woo University event. Begin with the lid in mind, Demodex Blepharitis and MGD with Dr. Paul Karpecki.
Thank you.
I'm your host, Dr. Jennifer Stewart, and thank you to Tarsus for providing a medical grant to support this event. So before we get started, there's a quick poll that comes up. So make sure you take the time, answer those two quick questions. The poll will stay up for a minute or so. So while that poll's up, and there's going to be a poll at the end too. So super important to just answer these two questions. While that poll's up there, just some housekeeping. For each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and throughout the presentation, make sure to use the Zoom on-screen floating panels to ask questions. We'll have time at the end, but put them in there throughout. Sometimes Dr. Karpecki looks at them, but so you don't have to forget. It moving forward.
Oh, sure. I can move it forward here.
Thank
Can.
you. So here's where you find the Q&A and chat on your mobile device. It's my great pleasure to once again introduce Dr. Karpecki. He received his Doctor of Optometry degree from Indiana University and completed a fellowship in medical cornea in Kansas City in affiliation with the Pennsylvania College of Optometry. He currently serves as the Director of Cornea and External Disease for the Kentucky Eye Institute in Lexington. He served as the TFOS DEWS 2 Diagnostic Methodology Subcommittee and the DEWS 3 Treatment Subcommittee, as well as co-chaired the previous two and upcoming TFOS Symposia. He's an associate professor at the Kentucky College of Optometry, teaching at the University of Pikeville. With that, Dr. Karpecki, I'm going to turn it over to you.
Jennifer, wonderful job as always. Thanks for the honor and the opportunity to do this. There's my financial disclosures. And then this poll, does it kind of come off of here on its own? Do I need to do something? Knock it off there. Oh, you're way ahead of me. There it is. Fantastic. So those were the easiest questions, actually. You're going to learn a little bit as we go along, I believe. Although, surprisingly, a lot of you got the right answer on the first one, which is interesting. So here's financial disclosures, the companies I do, advisory board, speakers bureau, that sort of thing, and all have been mitigated going into the presentation. So let's get right into it so we can save a little bit of time for Q&A. But feel free to put, as Jennifer said, just put anything in the chat area, and hopefully we can get to those questions before it ends. So we're going to begin with the lid in mind. You know, it's one of my favorite sayings when it comes to managing dry eye is just to start with the eyelid. In fact, people often say, hey, I'm trying to get into this dry eye a little bit more. Where do I begin? You begin by looking at the eyelid extremely well. And that's not just a flippant saying, because the fact is that 86% of all dry eye involves some meibomian gland dysfunction. And there's also the issue of blepharitis, MGD, that plays a role in that as well. In fact, look at this prevalence data. Of all the people that have dry eyes, I just mentioned 86% of them have some meibomian gland dysfunction. There's only 14% that don't. There's about 30% that have dry eye that's mixed with meibomian gland dysfunction and aqueous and mucin deficiency. But perimenopausal females, almost 80% have some level of MGD. So hormones play a role. Glaucoma patients, that's the one that really stands out for me. 96% of patients on prostaglandin therapy, on those most common glaucoma treatments, have MGD. If they're not on a prostaglandin, it's 58%, still pretty high. 58% of all diabetic patients have MGD. Uh, Patients who use digital devices extensively, 85% of them show signs of MGD. Cataract patients just coming in for cataract surgery is 59%, and contact lens wear, 60%. It's prevalent, it's everywhere. But the glaucoma one's amazing numbers, and dry eyes an amazing number as well. It comes up there. So if you're thinking of getting into ocular surface disease management even greater than ever in 2025, this can be 1 year goals, then this is where you begin. Can't say it any easier. You just got to look at the eyelid a little bit differently. Probably many of you are already doing this, but for those that aren't, this gives you a new way of kind of looking at the ocular surface, because so many times the eyelids give you the answers. Here's a great example. If you ever see frothy tear film, you can pretty much just put down MGD as your diagnosis, meibomian gland dysfunction. The reason you get that froth is because the enzymes that are present in bacteria and other pathogens reacts with poor lipids, dysfunctional lipids, and that creates something called saponification, which is like soap formation or bubbles or froth. And the great thing about ocular surface disease, I always say this, especially dry disease, that all the pieces of the puzzle fit together so beautifully. I mean, every day I'm in clinic, I get to the end of the day and think, wow, it's amazing how all of this just works. It all fits. Like a person who comes in with early MGD might see froth in their tear film, and their number one complaint is going to be burning and stinging. And again, makes sense. If you got soap in your eye, you're probably going to complain of burning and stinging. So it's very consistent in terms of the management. That being said, this isn't the most common presentation of MGD. In fact, it might be one of the least common presentations. More common is to just have to look real closely at an eyelid like this. In fact, I'm going to give you about 30 seconds to look at this eyelid really closely. And I want you to identify at least 5 pathologies that you see, 5 things that are just not normal lid signs that show up on this image. So 5. Let's see if we can do it. I started right when I first started talking, so I'm only going to give you about 5 more seconds. All right, one thing that stands out, of course, probably those telangiectatic vessels. Great indication of ocular rosacea or chronic inflammation, but more often rosacea. That's classic for it. Second thing you might notice is the cap glands posteriorly. So we had telangiectatic vessels. We have these glands that are capped towards the back. You can see kind of white caps on top. Normally shouldn't even show that there. What else might we see in this tear film? Probably see some collarettes. Now, normally we look for collarettes on the upper eyelids, but I could see some there on the lower eyelid. Another really important finding is the fact that these meibomian glands are so posterior in the eyelid. That placement being so far back is not normal. If you look at young children, you'll see the meibomian glands are actually a little anterior. With chronicity or thickening of the eyelid, we're not sure, or with age, they seem to move back. You've got collarettes at the base of the lashes here, which is another pathological sign of Demodex Blepharitis. We'll get into that. Debris in the tear film, that was a little tricky. I don't know if I would have picked that one up, but there it is. You have thickened eyelids or tylosis. That's a very thick eyelid that's present. You've got scalloped eyelid margins. A little hard to see that in a two-dimensional image, but those are really scalloped areas where you're seeing a little bending in. In 3D, you'd have seen it a little bit easier, but those are all some of the signs that are there. So it's amazing to look at this eyelid and think, wow, look at all this pathology that we can pick up just by examining that eyelid closely. And even then, you have to do a few extra things to be sure. Like if you look at this eyelid, you might notice a few lashes are curling upwards or downwards, maybe a few areas where lashes are missing. So you knew there's something going on, but really until the patient looks down, you can't tell there were collarettes, or at least not easily on the upper eyelid. So having the patient look down, cranking the magnification up one level will often help you identify the pathognomonic sign for Demodex blepharitis, which are the collarettes that are present. And then, again, to steal a page from Don Korb, actually, I quote Don Korb probably more than anybody, but it's hard not to. If you look at all the research that was done 20 years, a decade before anybody else was looking at this stuff well, Donald Korb was already publishing on it. He was the one who said the majority of meibomian gland dysfunction is what he called non-obvious. The only way you would know it existed is if you expressed the oil glands. You saw what was coming out. So while the last eyelids showed you quite a bit of pathology, the majority of eyes, you can't even tell they have MGD unless you take one more step, which is to express. Expression takes 5 seconds. I've had some docs come up to me and say, I love the dry eye information. I love this whole area, but do I have to really express oil glands? That seems a little different. And this was many years ago. And I thought about that at the time. And if I answered it today, I'd say that's like saying, I want to do more macular degeneration management, but do I have to look at the macula, or glaucoma management, but do I have to look at the nerve? 86% of dry eye involves dysfunctional meibomian glands. So you have to look for it. You have to press on the glands because the majority you do not have signs of. And I like the restored paddles. I think they're easy. You put them behind the eyelid, you lift upwards, the paddle you lift upwards, your thumb is external, and you just keep it stationary. And if it comes out like olive oil, clear, that's perfect. If it comes out like toothpaste like this, that's not normal. If it's turbid or discolored, or if it's not expressible, that's the worst case scenario that's present. So here's a patient that I would probably grade more. If 3 is a perfect score, that's probably a 2, maybe a 1. It is a little paste-like, but it's not coming out like the last images. That's not going to be sitting there. You actually have to take your paddle or your fingers and push on the eyelid or a double paddle, whatever you prefer, and just push upwards and see what's coming out of there. It's the only way to really get a diagnosis. It's a 3-second test. You don't need anesthetic for that. You don't have to press in the temporal glands. They don't work very well in most humans. Another study by Korb and Blackie. You're just really pressing in the lower eyelid, nasal to central region, maybe 5 glands, one pressure, see what comes out. If you have to press so hard that it causes pain, you're pressing too much. You're just trying to see what's coming out of there. That's why you don't need anesthetic. Is meibography helpful? Well, sure. Meibography help. Actually, some new studies that come out that show that upper eyelid meibography is even more important than the lower eyelid. In fact, a study showed that the most likely patients to drop out of contact lenses are those that had pathology on the upper eyelid, not so much on the lower eyelid. Patients with thyroid eye disease tend to have loss of upper eyelid meibomian glands in the middle. Fascinating. So much you can pick up from the upper eyelids. Here I've got a bunch of lower eyelid pictures, but still, it does help because I had patients where I pressed on the glands and nothing came out, but they had a wonderful row of glands. Or I've had patients like these examples where it's hard to find glands. There are just a few nubs on the one on the right, and on the left, there's maybe a few nasal, but not much else that are present. And these are a lot of the patients that come in for me. Now, a lot of people think, wow, this is so far gone. Can you really do anything for this? And the answer is yes. Another study by Korb showed that you only need, out of your 50 glands you're born with, in order to be asymptomatic, how many do you need to function? His studies showed 5.5. That's it. So I wouldn't give up on this patient. They probably have another 5.5 in their upper eyelid. You got plenty of glands. Even the nubs work. You just have to be more aggressive so you don't lose further number of glands here. Sometimes I have to look to see if the eyelids don't close. That's one of the number one causes of non-responsive dry eyes, something called ILS, inadequate lid seal. It's not really lagophthalmos, meaning lagophthalmos would be an eyelid up here and an eyelid down here. And you can get that, of course. People can have nerve palsies, Bell's palsy, where their eyelids, cosmetic surgery that wasn't done right, and they have true lagophthalmos. Inadequate lid seal is better thought of by the fact that anatomically your eyelids come together and at the tip and touch. That's the way you're supposed to sleep. That's what's supposed to allow the meibomian glands to recover. And in ILS, what happens is your opening is like this. But it doesn't matter if your opening is like that or like that. You're still getting a lot of drying out overnight. You're getting exposure keratitis eventually. The meibomian glands are not recovering. So if someone says they have any symptoms at all in the morning, that's not dry eye. Dry eye develops over the course of the day. In fact, the morning should be your very best time if you have dry eye. If patients say they have symptoms in the morning, their eyes are not closing. You don't necessarily need to do this test because just knowing they have symptoms in the morning tells you the answer. But I love doing this test. You darken the lane, and wouldn't you know it, the test is KB light test, Korb Blackie light test. I don't know, I sometimes feel bad that I quote Korb so much, but there's no one else who's got all this research that really helped to set the stage for us today to understand this field so well. And he's a great optometrist, great researcher, great observer. So in his test, he and Korb and Blackie said you go into a darkened lane, you have the patient close her eyes but not squeeze, you put a transilluminator or bright light at the top of the tarsus, and you look for light coming down at the bottom. It is a pretty cool test, very exact for the disease. And even if you look at the TFOS-DU's diagnostic methodology, my favorite diagnostic methodology by far, and you're probably thinking I'm biased because this is the committee I was on, but the reason it is so good is it's so practical. I mean, you look for symptoms, you look for one sign like osmolarity or ocular surface staining or non-invasive breakup time, and then you differentiate the type of dry eye. If it's MGD, you can tell if it's there by expression. And if it's aqueous deficient, you can tell that's there by the tear meniscus height. But my point to this is you've got to do the differential. You've got to be able to express those oil glands to know what kind of dry eye it is, because if you don't know the type of dry eye, like evaporative from meibomian gland dysfunction or aqueous deficient from lacrimal gland dysfunction, you don't have the right algorithm. So expression of that lower to nasal central eyelid is so critical. Here's a good example. The algorithm that I've used for probably about 11 or 12 years now for evaporative dry eye is something I call OBIT. You got to control the obstructed glands. You got to control blepharitis or biofilm. You got to control inflammation and then the tear film. And eventually the tear film works on its own. You don't have to do too much for that, but at the beginning you do. So this has really panned out well over the years. If I go back to when I started my first dedicated dry eye clinic, which is, I hate to admit this, 27 years ago, this 2025, I've been at this, and it was frustrating. I remember coming in some days in clinic where half the people would ask if there was another doctor they could see. Kind of a nice way of saying, you don't know what you're doing, do you? So we didn't have a lot of choices back then. We had plugs, we had artificial tears, steroids off label, um, maybe some ointments. That was it. So no wonder we didn't know what we were doing, couldn't get some good success. Then we realized after treating the tear film, maybe we should treat inflammation. 19 years ago, we had cyclosporin approved. And we got a little bit of success, maybe 15%. Then we started saying, wait a minute, if the oil glands are obstructed, we got to use some of these hydrating compresses. We got to get them working. And we got up to like 55 or 60%. And the toughest one for me to add to my algorithm was that second one, biofilm. I'd look at eyelids and not see much pathology. I mean, I was looking for Demodex 20 years ago. So I know what to look for. And I'd be looking and I'm thinking, there's not much here. But I would still look at some of the Hank Perry study that showed that 94% of evaporative dry eye, when you express the oil glands or you pluck an eyelash and you look for bacteria, it's present 94% of the time. But that was tough for me to say, why would I clean the eyelids up if I don't see any signs? At least with expression, I know there's signs because I'm pushing on the oil glands to see what's coming out. But when I started adding the B in, our success went up over 80%. And now little things like inadequate lid seal, things like that have helped us get closer to not 100%, but getting closer for sure. So there are places for things like hydrating compresses, but you have to use the ones that are on the market. These ones have studies that have shown you can maintain about 113 degrees for 8 to 10 minutes. And that's what's necessary to really change the obstruction. You're not going to get away with rice in a sock or some of the old things we used to do. You're not going to get with dry heat. People say, well, can I use dry heat? That's like if you put your hand in an oven, which is dry heat, it won't burn unless you touch the racks. Not for a while, won't. And that's 400 degrees, we'll say, an average oven. But if you took your hand, you put it in 212 degrees of boiling water, you're going to the ER. Hydration is what penetrates. So it has to be a hydrating compress to work. Things like debridement are extremely helpful. Being able to remove the caps off the glands goes so far. In fact, I had a patient who literally came into my clinic. This was many, many years ago. And I now do debridement because you don't need anesthetic for this. In fact, you would never want to use anesthetic because the feeling they get after remove all that biofilm and all that obstruction is so good that they leave thinking that's the best I've ever felt. And that's 5 seconds to 10 seconds of work. Anyways, this lady called, and this was maybe 8 or 9, 10 years ago, and I didn't do this on every patient like I do today. And she said, Dr. Karpek, you forgot to do that thing to my eyelid. And I said, thing to my eyelid? Oh, the debridement. I said, well, have her come back. I apologize. I'll go ahead and do that. I just thought her oil glands were doing so well. I didn't bother. Carla comes in and says, well, the patient lives 45 minutes away. I said, oh, well, let's just get her on the next visit. The lady drove back. So she already drove in 45 minutes, went home 45 minutes. That's an hour and a half. Drove back 45 minutes for me to do a debridement. I took like a minute. I think I even did the upper, which I never do, because I thought, man, if she drove 3 hours, 45, yeah, 3 hours. I better do this debridement really well. But my point to that story is just the impact it has on patients, something as simple as a 5-second debridement. So treating bacteria was the toughest part of my algorithm to get behind because I'm like, if I don't see it, but look to the right, that's a biofilm. That white sheen is bacterial biofilm. That's what that is. So many times there are things I didn't even know to look for. Collarettes. Anybody who has Demodex has a bacterial component. Demodex brings in all kinds of bad bacteria with them. So you're going to have that present. And the study showed 94% of all evaporative dry eye have some sort of biofilm. So even just adding a lid scrub often will help your success when you're treating evaporative dry eye, even when you can't see a lot there. Blepharoexfoliation, the ability to get rid of these collarettes. But keep in mind that while it is nice to remove them, look at the bottom level there. We just did a microblepharoexfoliation. Everything's gone. It's a little bit like removing the sawdust, but not killing the termites. So you got to really do both. I think that becomes extremely important to also treat the disease. But patients will do so well by doing debridements, by removing all of the blepharoexfoliation treatments to go ahead and get rid of all this collarettes and debris really help. Thermal expression treatments in the office do well as an option, provided when you express, you can get stuff out. If you express and nothing comes out, I don't tend to do these. I like an IPL with an LLLT instead. I'm a big fan of intense pulse light therapy. I love some of the newer systems now where you don't have to put coupling gel on the face. They don't feel like an elastic band snapping on the face. You can treat more skin types and they're like half the price. It makes no sense, but they're just keep advancing. And you get LLLT with it. So you get this added heat that you can add for 15 minutes at the end. There's something in 2025 called an ELM coming out, eye lipid mobilizer. I love what that can do in clinical trials. I was one of the study sites for it, and I was amazed at how well that did. Even things where you apply the applicators to the upper and lower eyelid and heat and then express are very helpful for these patients. IPL really is ideal if you're treating things like rosacea, where you see these telangiectatic vessels, because it kills the trunk and then the vessels start to shrink. And all those vessels that brought in inflammation can no longer do that now. So it targets those telangiectatic erythematous blood vessels, those highly gorged blood vessels and others. It affects mitochondrial activity. It activates the cytochrome C pathway so the glands start functioning on their own again. I had great success with it. But LLLT is different. That's low-level light therapy. And you can't just go buy these at Amazon. They don't penetrate the dermis enough to work. But here's a study that compared low-level light therapy, showing how compatible it is with IPL, intense pulse light therapy, because they measured heat in the eyelid and in the cheek and all these other areas after one treatment of each one. And what's fascinating, if you look at the data, the darkest statistical improvement. So IPL, let's look at the lower eyelid. That's the most important statistic area to improve. It showed only at 2 minutes, only the cheek maintained a little bit of heat. There was no change in the eyelids. But go to the bottom there, low-level light therapy. 25 minutes later, you still have statistically significant greater heat in the eyelids. 25 minutes later, that means the body's producing its own heat. That's endogenous. And that's why it works so well for hordeola and chalazion. I haven't had to cut out a chalazion at all last year. I remember having some Fridays where I would remove 8. Patients, we line them up, and it's never a fun procedure for the patient, especially, nor for me, really. I never really enjoyed removing them. Now we do these low-level light therapies. If you catch them at a hordeolum level, they're really successful. If the chalazion has been there a long time and is large, you can make it a little smaller, but you won't get rid of it with an LLLT. But you certainly will with hordeola and early chalazion. And I think it's that endogenous heat that allows that to happen. What about perfluorohexyloctane? New drug that got approved last year, mimics the lipid layer beautifully. In fact, it actually prevents evaporation 4 times better than our lipid layer. That's a really good lipomimetic, so to speak. The way I present this to patients is this is a terrific drop for evaporative dry eye patients. While we're trying to make your oils work better, I'm going to put you on a drop that mimics your oils until they can get better on their own and allow you to have good vision, allow you to have comfort, and be a good treatment for this type of dry eye. Hopefully, we can get your oil glands so good with IPLs and LLLTs and hydrating compresses and the biofilm treatment and inflammation control that we can eventually not need it, but there are many who love it so much they'll never come off of this drop. It is preservative free. It is water free. It's a single agent drop. It has shown great ability to create a monolayer that works better than our own oils at age 50, and it retains itself in the tear film for 6 hours, in the meibomian glands for 24 hours, and really one of the safest drugs we've ever seen. In fact, I think there's only one person out of 614 that dropped out of the trials. And you can see a significant improvement in staining. Now, remember that first question you got in the polling that said, which of these medications actually affected the oil gland functioning, the liquid secretions? My guess would have been this drug, right? Because it kind of mimics it. Actually, not. Their primary endpoint was total choroidal fluorescein staining. That's what they're looking at. And the data is great. Statistical at day 15 continues to advance, but still statistical at the same level at day 57, the primary endpoint. And great profile. One person out of 614 dropped out. 3 out of 614 mentioned burning, and 13 out of 614 mentioned blurred vision. So overall, very good safety profile. If there's any disadvantage to this drop, it's probably this one. It's hard to know it's in the eye. It's such a comfortable drop. It's such a tiny drop. People often say, well, why do they make the drop so small? Keep in mind, if you were in a, let's say, a football field, since we're in the playoffs for college football, and you took that entire football field and you said, okay, how thick is the lipid layer relative to that field? It would be a little more than dental floss. It is that thin relative to the tear film that's aqueous and mucin. So 11 microliters in a drop is probably very appropriate, even though patients may say they have trouble feeling it going in the eye. There's not even a blink reflex kind of with it. And then the other thing we really need to take some time to look at here is this whole as Demodex blepharitis, the number one cause of blepharitis by far. 25 million people have this. There's two forms, follicularum that gets in the lashes and brevis that gets in the sebaceous glands and probably gets into the meibomian glands as well. If you look at the prevalence data based on the Titan study of 1,032 patients, 58% of patients who had, that walked into any optometry office, 58% had Demodex blepharitis. 65% of glaucoma patients have Demodex blepharitis. Contact lens wearers, 51. Cataract patients, 56. Dry eye patients, 60% of all dry eye patients have collarettes indicative of Demodex. Almost 70% of all blepharitis is Demodex. It's the number one cause. And those with MGD, 57%. And now we have a drug for it. Lotilaner 0.25% is a on-label drug for Demodex blepharitis. It's really interesting because this drug actually came from veterinary medicine, much like cyclosporin came from veterinary medicine 20 years ago. This is used to kill what's called mange in dogs and cats, which is Demodex infestation. And it works by paralyzing the mite via the GABA inhibition in this. And we don't have a GABA pathway, so it's not going to affect humans, but it sure does wipe out mites, paralyzes them, knocks them out on contact, and incredibly effective, as you may have seen for those who've prescribed this drug. And you can see the majority of patients here from baseline to day 28, very consistent improvement in their collarettes and their blepharitis. The drop is prescribed twice a day for 6 weeks. I guess if there's a disadvantage to this drop is it's so quickly effective, meaning like 2 or 3 weeks into it, patients are like, "This is the best my eyelids have ever felt. There's no more itching. I don't have fluctuating vision anymore. All these crustiness in my lashes is gone," but they can't stop. Remember, the Demodex adults has a life cycle of about 18 to 20 days. So let's assume 21 is 3 weeks. The eggs have another life cycle of 18 to 20 days. So if you stop at 3 weeks because the eyelids feel so good, they're all going to come back from the eggs and the nits. So you have to go the full 6 weeks twice a day. And look at the data when you do that. XDEMVY, compared to the number of patients who had collarettes of 2 or less across all the lashes, they started with around 150. So 2 or less, you're looking at 44% versus only 7% for the vehicle. And then in the other next study, it was kind of very similar in terms of the numbers, and only 12% for the vehicle there. So it hit its primary endpoint, hit secondary endpoints as well, which is erythema cure rate at 3 weeks. That is, the redness went away. There's no steroid in this. It's just when you kill the pathogen, the eye can really heal up. 56% of patients had a collarette cure versus 13% for the vehicle. And 90% of patients reported the drop is very comfortable to neutral. There was about 7.9% that mentioned burning. Visual acuity changes was one patient out of 203. Dry eye was three patients out of 203. So very nice safety profile as well. But here's the newest research to come out is, wait a minute, yes, we want to treat the lash follicles, the Demodex follicularum, but why are patients doing so well who have meibomian gland dysfunction? And if you look, perhaps it's Demodex brevis. That's the theory right now, that it's getting in the meibomian glands, and it is what's causing that obstruction and affecting the pores and maybe leading to MGD. So they decided to look at lotilaner, not just for blepharitis externally, but for MGD. And this is called the Ersa phase 2A study, where they looked at its effects specifically and discovered that they looked at gland secretion scores. So that question on, improving meibomian gland scores, maybe that's the answer here. TPO3 lotilaner demonstrated statistically significant improvement compared to baseline in gland secretion scores, MGSS, at day 43 and day 85. Number of glands secreting meibum statistically significantly improved. And although they had a 3 times a day arm and a twice a day arm, they were equal, but the vehicle did not have any effect at all. So this is a lot of data to just show you what you just saw, that the meibomian glands yielding liquid secretion statistically improved with the lotilaner, did not change at all with the vehicle. Let me show it to you this way. So the number of glands yielding any liquids of secretion, a score of 2 to 3, and those yielding liquid secretions, you can see statistical improvement. And they were pretty much the same at baseline, 7.1 versus 7.3. That's the vehicle versus lotilaner. But there you are, day 43 with statistical improvement, P of less than 0.0001. And then again, statistical of 0.01 at day 85. So it was maintained. Specifically, if you look at itching, statistical improvement, no change in the vehicle. If you look at the next study down, we saw the same thing that was present. If you look at redness, and fluctuating vision, that was supposed to be the other one that was statistically improved. The vehicle did not change. Redness statistically improved, fluctuating vision, itching, redness, and burning. Interesting. All of a sudden now we have theories that may say maybe Demodex is a culprit of why we see these symptoms and why we have MGD as well. Now, I will tell you, I still combine the lid scrubs with them. I know in the clinical trials, they were not allowed to touch the eyelashes, and they still had the data that you see earlier. But I tell patients to use a lot of people say, well, I'm a big fan of the Manuka lid scrubs. I think they work phenomenally well for maintenance, but they would never treat a high level of Demodex. And in a way, it's kind of like taking a sledgehammer, which is your lotilaner, 0.25%, and then taking a fly swatter afterwards. I'm not saying a Manuka is that weak. It's actually pretty good, but it's not the same. So I like the Manuka long term after they get past their 6 weeks. I like lipase, your common, surfactant eyelid cleaners, not hypochlorous acid. In fact, hypochlorous acid was not shown to affect Demodex at all. I love hypochlorous acid for staph blepharitis, but for Demodex, there was a study by Al Cabot that showed it had zero impact on the mite. They were still doing the backstroke under the slide 9 hours later after being in hypochlorous acid, but it was good for bacteria. So I'd rather use, since the food source of Demodex are dysfunctional lipids, you're better to use an eyelid hygiene product, your Lid Scrub Plus, that sort of thing. Then go to Manuka long term. You can certainly start them on fluorohexyloctane at the same time too, if you're able to get 2 drugs through as well. And even omega fatty acids have been shown to be effective. And now you're looking at this saying, wait a minute, I thought the DREAM study showed that fish oils didn't really work. Not true. They showed really significant improvement from baseline. It's just that the vehicle, or the comparator, olive oil, also showed a highly statistical improvement from baseline. But there is one omega fatty acid that has a ton of research behind it. I'm always surprised that it's not as well known as it could be, and it's gamma-linolenic acid. And I think the reason why we don't know it as well is because it's actually an omega-6 that becomes a 3 that targets PGE1. That's the heart of inflammation and control, and it works incredibly well. Now, you do have to have fish oil with it. It is combined with fish oil. But that combination seems to act on the lipid layer better than any other combination we've ever seen. And in fact, if you want to go through the research, there's studies on GLA showing highly statistical improvement. So the people say, oh, there's no studies on fish oil showing a significant improvement in dry eye. Maybe. There may not be fish oil. That's EPA DHA. But if you look at GLA with EPA DHA, I found 7 studies just putting this presentation together. Aqueous deficient dry eye, PRK dry eye, Sjogren's syndrome dry eye, contact lens dry eye, meibomian gland dysfunction, moderate dry eye, including evaporative dry eye, and postmenopausal women most commonly with evaporative dry eye. All statistical, all very scientific studies. And then watch for morning symptoms. It is a real common cause of, I would say that 90% of the patients who have inadequate lid seal, I think this patient has really ophthalmos, though, is a little more than just inadequate lid seal. 90% of patients, though, who have any sort of non-closure, whether it's this bad or the images I showed you earlier, have Demodex. I don't know if the parasites, the mites get in a little better or what's going on there. They have MGD. And if it's left long enough, they get exposure keratitis as well, like this. I'm a big fan of loteprednol if you get to the stage of steroid of a inferior exposure keratitis. They put this in at nighttime for 2 weeks and just clear things up beautifully. It's preservative free, which is kind of nice as well. So a person who has morning symptoms is not typically dry eye. This is inadequate lid seal. It does lead to meibomian gland dysfunction. It eventually leads to evaporative dry eye, exposure keratitis, but it's not truly lag ophthalmos. It's the non-seal is what it is. But either way, eventually in your 40s, 50s, 60s, you finally can't compensate for that anymore. And it's there. And the question is, why does this happen? Well, a lot of people are born with it. I'm one of them. My left eye doesn't close. In fact, I could wink this right eye. I cannot wink my left eye at all. And I have 2 of my 3 children. Their left eye doesn't close at night. I could see it looking in there. I'm thinking, oh man, that's not the thing to have inherited. But one doesn't, one closes all the way, and they're going to have the same problems as me. Mine got pretty bad. I had terrible recurrent erosion. I think I went into cornea just because I was trying to fix my own eye over all these years. And this was the problem. It was inadequate lid seal. And so now there are new treatments that are very effective. Ointments are okay. They have about a 50% or 40% success. Not huge, but it's better than nothing. Sleep masks don't do much. They block maybe a fan or a ceiling fan, so there's some benefit there. But these eyelid seals, these strips, and I tell patients, people use nasal strips to breathe better at night. These are eyelid strips that are on there. In fact, I had a patient, that's right before the holiday, said, yeah, I'm looking really good. I've got nasal strips, I've got eyelid strips, and I have a CPAP. So that's pretty attractive at night. But nevertheless, these are what people do nowadays, and these seals are really good. They're oxygen permeable, they're hypoallergenic, they're latex free, they don't pull off lashes, and you just have to place. The key is you got to, they got to seal. So sometimes you got to use a little cleaner that gets the oils off for it to stay at night. But patients who use this get almost 100% success. That doesn't mean 100% of people can wear these. Some people pull them off at night. Some don't stay. Some don't like the feel of it. There's also a huge group of patients who say it's the best sleep they've ever had once they started using these, because they probably had the eyelids were a little open and light was getting in. But nevertheless, this is at least a treatment that addresses this condition as well.